First of all, let me express my thanks and note my really sincere thanks to the National Academy of Sciences for hosting this wonderful event, an event that's long overdue. And it's been a pleasure, will be a pleasure, sharing podium and platform with Jennifer and Dan. Jennifer, again, thank you for your excellent presentation. I'm going to speak about some of the experiences that I and the opera team have had over the last decade or so related to some of our evolving concepts of how we should visualize, at least in my view, TMD, how we can divide it into different types of diagnostic categories and how it can begin to inform treatment for our patients in the future. A guiding principle that I'd like to promote, not only for TMD, but for many of the other conditions that Dan alluded to just a while ago. When we think about common chronic pain conditions, such as TMD, they really present over time as a dynamic kaleidoscope of signs and symptoms. So at one point in time, there will be a set of signs and symptoms, oftentimes revolving around the chief complaint of pain. But there are oftentimes, in fact, more frequently than not, a number of other symptoms and what we would call intermediate phenotypes that the patient presents with, which are dependent upon the life experience of the patient, the types of surgeries that they've had, the type of events they've experienced in their daily life over the last several weeks. So a variety of environmental factors combined with the individual's own susceptibility based on their genetic code dictates this kaleidoscope of ever-changing signs and symptoms that patients present with. And so this is a guiding principle that I think that we should hold in mind when we begin to think about how do we develop diagnostic criteria for TMD, how do we begin to develop new treatment concepts for TMD. What I have said on this slide is presented in graphic form in this slide, and many of you have seen this slide many times. This slide says that patients who are destined to develop persistent pain, that there are a variety of domains in the biopsychosocial sphere that influence and interact to produce this kaleidoscope of signs and symptoms, which are dependent upon life history, environmental exposures, and how those exposures influence the coding and the expression of our genome and omic metrics of our genome that influence by biological processes the signs and symptoms that our patients, including TMD patients, express. And part of our work over the last many years has been to try to unravel primarily the coding properties, these intermediate phenotypes that interact to produce the patient that sits in front of us. And so what I will do is talk to you a little bit about how we've taken certain approaches from big data sets like OPERA to develop some new ways of thinking about TMD patients from a diagnostic perspective. But this model must also explain what Dan just spoke about. That is that some of these, if you will, pathways of susceptibility not only contribute to TMD, but also can contribute to pain that expresses in other anatomical sites. And we know that this model must take that approach because, as Dan mentioned, we know that conditions like TMD are highly promiscuous. They are associated with a variety of other chronic pain conditions. So, for example, if you look at TMD, we find that about 24% of fibro patients meet criteria for TMD, 64 for IBS, and chronic fatigue syndrome. So as noted in the article that Dan started with in his presentation, these data are beginning to support the notion of the overlap and the pleiotropic nature of conditions like TMD. Therefore, we must have models that not only take an axis 1 approach to TMD, but take a broader approach that can explain the etiological mechanisms by which TMD and related conditions develop. Now, the OPERA team, co-authors on this paper, have taken several approaches to take big data and to begin to identify new ways of classifying patients with painful temporomandibular joint disorders. This approach, which was pioneered by Eric Baer in our program, used a set of machine learning methodologies and clustering methodologies on 202 phenotypes that we collected in several thousand patients seen in the OPERA study. That process resulted in a methodology, a clustering methodology, whereby we can classify patients into one of three groups using 4 variables. Somatic awareness, which we believe is a metric of the augmentation of central sensitization, anxiety, depression, and a quantitative sensory measure of pressure pain sensitivity from the trapezius. So OPERA reduced 202 phenotypes that we collected prospectively. We've identified, of those 202, 4 phenotypes that we can use in an algorithm to classify TMD patients into one of 3 groupings. And I believe that these are, in fact, diagnostic groupings that we are currently using in our clinics. So the first grouping that we identified is called the adaptive cluster, and actually this may be more akin to Dan's nociceptive cluster. The second cluster of individuals that we identified are called pain-sensitive cluster, or pain-sensitive individuals. And then the third is a global symptoms cluster, which I think more in line with Dan's central sensitization cluster. So using these 4 measures that we can obtain prior to or during the intake of a patient's visit, we can classify a given patient into one of these 3 clusters. And when we look at the portrait that these 3 clusters present with, we see that they are quite discrete in their presentation. So individuals who are in this adaptive cluster, if we look at a measure such as pressure pain on their trapezius, and these are z-scores that are being plotted, so at this end, individuals are less sensitive to the pressure compared to others at this end. So individuals who have been relegated by the algorithm to the adaptive cluster, you can see as a population, they are less sensitive to pressure pain than the pain-sensitive cluster or the GS, the global symptoms cluster. And we find that this is the case for almost any pain metric that we subject these individuals to. We looked at a variety of QST measures in this population. I display some of the more profound ones here, but you could take your favorite QST measure and you will find that it divides these individuals up into these groupings, including wind-up, a measure of central sensitization, or central sensitization metrics of pain sensitivity. They all fall into this type of a differentiation. The adaptive cluster less sensitive, while the pain-sensitive cluster more, and the globally distressed also more relative to the adaptive. If we look at certain other, if you will, psychological or psychosocial measures, we also see that the globally, what I call the globally distressed or the global symptoms cluster, they are more profoundly impacted than the other 2 groups. And I think this also goes with Dan's notion of central sensitization. Though psychological factors are viewed differently in his model, if one were to look, I think, in an antecedent way, he would find some glimmer of anxiety, depression, and somatic awareness as predictive of who ends up in the more widespread pain cluster. I'd also just like to note that the number of body sites that are tender to palpation greatly enhanced in our group 3, and the number of comorbid conditions greatly enhanced in the 3rd group. If we ask the question, what is the likelihood that you're going to develop a condition like TMD based on your placement in a cluster prior to the development of the condition? And you can see that individuals who start out in group 3, that they're about 3 times more likely to develop TMD over a 5-year, really a 3-year observational period compared to individuals that were relegated to groups 1 and 2 prior to the development of the condition. If we begin to ask questions of the algorithm and the distribution and the profile of individuals in these different clusters, if we ask what is their clinical portrait, I'll just emphasize that the algorithms and the clustering methods that were used did not take into account any of the clinical features of these patients. So we use biopsychosocial pain sensitivity to create the assignment. Now we ask the question, what is your clinical portrait based on your cluster assignment? And what you can see quite readily that independent of the clinical pain measure that we use, whether it be a VAS scale or whether it be a word scale from the Gracely scale, that we find that the GS cluster has higher levels of pain, both in the way of intensity, unpleasantness, the percentage of the time during the waking day that they experience pain is also greater. There's almost a dose response to some of these measures based on their cluster assignment. If we look at interference, facial interference, SF12 physical function, the number of body sites that are sensitive to palpation, general health status, mental health status, again we see that group 3 is severely impacted compared to the other 2. One thing I would like to point out is an account of the 20 comorbid conditions that we assessed in OPERA. If you end up in group 1, it's likely that you have about 1 comorbid condition. If you're in group 3, you have over 4 comorbid conditions. So a strategy now has been developed that allows us to very simply, quickly identify patients, to put them into different groups where we think this kind of information will begin to move away from the traditional, will incorporate, but will begin to move away from the traditional Axis 1 diagnosis to create a new paradigm shift where the diagnosis is based on a biopsychosocial model rather than anatomically specific or necessarily Axis 1 specific diagnoses. I'll just show you a little bit more data in this area. If we ask by cluster, what is the percentage, what is the proportion of TMD patients that fall in these different clusters from our cohort studies? And you see that in cluster 3 of controls versus TMD, we find a higher percentage of TMD patients making up cluster 3. If we look at other types of conditions that we assessed in OPERA, IBS, vulvodynia, lower chronic pain, chronic headache, we find enrichment in cluster 3 for these patients, suggesting that this algorithm may in fact be agnostic to anatomical site, but maybe tapping into some of the fundamental mechanisms that Dan noted that allows us to classify patients by biopsychosocial profile that allows us to go in and label anatomically their condition, TMD, lower back pain, IBS, or combinations thereof, which I think is very important if we're going to create a paradigm shift where we're moving away from simple Axis 1 anatomically based diagnoses and beginning to look at the pathways of vulnerability that are truly contributing to these very, very complex patients. So this speaks to a method, one of several types of methods, where we're looking at the patient more holistically and beginning to map on, if you will, their anatomical pain condition to fundamental etiological pathways that are contributing to their conditions. So I'd like just to also note that from these studies, there is discovery occurring that I'll share just briefly with you that are coming out of the OPERA cohort and other cohorts. And some of the primary findings that we're now now seeing is that inflammatory and neuroimmune markers are becoming more and more prominent and evident, again suggesting a more global dysregulation of these patients than something that is strictly anatomical to the head and neck. So we have published and have shown that inflammatory cytokines such as MCP1, IL-1 beta, IL-1RA, IL-8 are increased in TMD patients, and the transcriptional factor TGF-beta1 is decreased in TMD patients. And recent studies that my colleague Luda Diachenko and others at McGill have been pursuing have shown that using pathway analyses, using human DRG data sets and our own GWAS data sets from OPERA, we're now beginning to see that there are dysregulations in T and B cell signaling in HLA regions of the genome, and that there are, in fact, areas, certain signaling pathways related to the SMAD pathway, SMAD1 in particular, which may be very fundamental in mediating some of the signs and symptoms that we see in TMD patients. And finally, just some ongoing recent data that Luda Diachenko and I have collected from patients at Duke in our Briar Creek clinic. On 30 patients, we've been able to show that individuals in this third cluster, relative to the A cluster, preliminary data, that we're finding abnormalities in the increased levels of helper T cells, and transitional monocytes of two types, and in the non-classic monocytes. So we're doing a very deep dive now in the immunology of these patients, and already with just a few patients we're beginning to glean some differences. So lessons learned, I think this goes very much to the heart of what Jennifer was saying. I think that we should now recognize that painful TMD is no longer your grandfather's Chevy. It is something quite different. It's now, I think, a misnomer and no longer appropriate to regard TMD solely as a localized orofacial pain condition. It is pointless to envision a single cause, nor even to expect that any one cause might be necessary or sufficient to explain TMD. For the majority of people with chronic TMD, the condition is multi-system disorder with overlapping comorbidity. I think I'll stop at this point and would like to thank you for entertaining the presentation today.